Let's now talk about the vasomotor center. The vasomotor center is a little bit easier because it's purely sympathetic. Okay, there's no parasympathetic division. The vasomotor center sends efferent fibers down to arteries and arterioles. Okay. But it also sends efferent fibers down to veins. So let's draw these fibers up. Because these are sympathetic fibers, they release norepinephrine. And norepinephrine is going to bind to adrenergic receptors within these peripheral blood vessels. Most of these adrenergic receptors are of the alpha-1 subtype. These would be alpha-1. Okay? But when these alpha-1 receptors are stimulated by norepinephrine, the vessels undergo vasoconstriction. Okay? So this is going to bring about vasoconstriction of both the arteries and veins. Now, when veins undergo vasoconstriction, we can use a special term. We can call it venoconstriction. Venoconstriction. See what I did there? I went veno on you. If you vasoconstrict arteries and arterioles, that's going to lead to an increase in systemic vascular resistance, which elevates blood pressure. Remember, SVR, systemic vascular resistance, is one of those factors that influences blood pressure. If you venoconstrict, that's going to increase venous return to the heart. Why? Because when you constrict a vein, you increase the intravascular pressure. And so you increase the pressure gradient driving the blood back to the heart. All right, and so if you increase venous return, by the way, increasing venous return is going to increase stroke volume. More blood coming into the heart means that more blood is going to be ejected, a higher stroke volume, which ultimately is going to increase cardiac output. Okay, so let's see. So when, here's our, let's put our nucleus tractus solidarius here. Okay. When blood pressure is low, and there's a drop in blood pressure, as reflected by decreased stretch within the baroreceptors, okay, and that information comes up to the nucleus tractus solidarius, it's going to stimulate the vasomotor center, leading to vasoconstriction and venoconstriction. That's going to raise systemic vascular resistance and stroke volume, and that's going to elevate blood pressure. So in addition to these cardiac mechanisms, a drop in blood pressure is also going to cause vasoconstriction, which will augment blood pressure through these two mechanisms. On the other hand, if blood pressure is low, if it's high, then simply we inhibit. We block impulses traveling down the efferent fibers to the blood vessels, and without that sympathetic input, the vessels vasodilate. If the vessels vasodilate, we lower systemic vascular resistance and drop blood pressure. If the veins vasodilate, we decrease venous return, decreasing stroke volume. I'll give you an example. Is everyone up to date? Has everyone figured this out now? Is everyone good? When we transfer from a supine position to a standing position, blood transiently, very transiently cools in our lower extremity. Okay? Because of the effect of gravity. Okay, so we're going to stand, there's a transient decrease in venous return that's going to cause a drop in blood pressure. Because with decreased venous return, we have decreased stroke volume and our blood pressure falls. But you and I don't notice it. Why? Because within seconds, what happens? With a drop in blood pressure, we activate the sympathetic components of the cardiac center and the vasomotor center. So as soon as we stand up and our blood pressure starts to drop, our heart rate goes up. Force of contraction increases, and we get vasoconstriction. And it happens so rapidly that we don't even have a chance to become dizzy or lightheaded. We don't feel the drop in blood pressure.
So if you do become lightheaded, does that mean there might be a problem with your sympathetic nervous system?
It could be.
Like it doesn't react fast enough?
It could be. Well, that's what happens to all of our reflexes as we age. Talk to a lot of old people. When they stand up, many times they get a little dizzy because those reflexes are a little bit slow to kick in. So you have to tell old people when you stand up, hold on to something for a few seconds until you feel okay, and then you can walk. But that happens in a lot of elderly. And then the other thing is that medications can block some of these responses. You can give, for instance, an alpha blocker for the prostate gland for someone who's got BPH. It's going to relax the prostate so it doesn't constrict the urethra. But it's also going to block these alpha-1 receptors. And so it's going to inhibit or block this mechanism that serves to return blood pressure up to normal when we stand. So for patients who you put on an alpha blocker for BPH, you have to warn them, particularly when they first start the drug, that when they stand up, they're going to feel a little lightheaded. Because that drug is non-selective. It's also going to act on other alpha-1 receptors.
So is that the same thing that happens like when, just a normal healthy person like is laying down and stands up?
If you stand up too quickly, right, you can feel it. Just, what happens is prolonged bed rest. The longer you're down, the slower the reflexes. People who have been lying down for a long period of time, like they've been bedbound, you can't just stand them up again because they'll pass out. So in a hospital setting, if someone's been bedbound for a week, then you have to take them through stages. Okay, where they first just dangle their feet. They don't get out of bed, but they just dangle. And then the next step is getting them up into a chair. And they'll do that for a couple of days. And then the next step is to actually stand them up with assistance. Okay, so they have to get used to the change of position. Okay, because their reflexes, particularly after prolonged bed rest, are going to be slow. So this autonomic nervous system plays a major role in second to second, minute to minute changes in blood pressure. So this is what we call short-term control. JJ, you with me? We cool? Everything's copacetic?
Dr. Fenner, how'd you get into cardiology? Like, why'd you choose that as your specialty?
Because in the beginning, I wanted to do procedures.
Mm-hmm.
Okay, I didn't want to simply diagnose and treat. I wanted to do stuff with my hands. So that's how I got into it. And I liked it. I remember as a medical student,
Mhm.
having a patient come into the ER and running, what they call it, a cardiology fellow, taking the patient up to the cath lab with the cardiac fellow and putting a pacemaker in the patient, and all of a sudden his heart rate went up, and all of a sudden he perked up again, and he could walk and do things that he couldn't do when he came in. And so it was a dramatic change, okay? Or seeing people, come in with arrhythmias, you shock them, and all of a sudden they're back,
Mhm.
So I like the fact that you could do procedures that would have an immediate impact. Or you take somebody who was having, threatening an MI, and you put a catheter in their heart, and you open up the vessel, and all of a sudden the pain goes away.
So it's more direct.
It's more direct, yeah. As opposed to, let's say, if you're an internist, you may give a pill and have the patient come back in a month and see a small drop in blood pressure. You don't feel as good. I mean, it's good, but it's not as exciting. But after a while, even though those things that you go in,
Mhm.
it's kind of a double-edged sword, because MIs and those emergencies oftentimes occur at like 1 to 2 or 3 o'clock in the morning.
Yeah.
And so you're constantly being awoken to get to the ER.
Mhm.
So after a while, that gets tiresome. What was fun in the beginning becomes kind of routine, and it's bad for your family life.
So is that why you chose to retire?
Well, that's why after Katrina, when the office flooded,
Mhm.
I said, well, now's a good time. Because I would have had to then build,
Yeah.
done some renovation, and
You're like,
it's a
okay.
mess. I lost a lot of records, they were all flooded. I was on the first floor of the building. And so it was just a good time. Sometimes God does for you what you can't do for yourself. So I have a much better life now. My kids used to always complain that I was never there. And so it was a good time to...
So you retired once they moved away, and now?
No, they were still, they were in college, right. One of them was in college, one was in high school still. So,
So you're able to catch up.
but I was able to go to college. Then I would start taking trips up to the college, and I could do things that otherwise I couldn't do. All right. Let's do this. So what these next few slides do in words is to explain what we just did in pictures. There's the cardioinhibitory center, which sends impulses to the SA and AV nodes to slow down the heart. And then the cardioacceleratory center, part of the sympathetic nervous system, which sends impulses to the SA and AV node to accelerate heart rate and increase force of contraction. And then we talked about the vasomotor center, which is purely sympathetic. Okay. And this is a picture from your textbook that just demonstrates the concept, and this is part of homeostasis. This is a homeostatic mechanism where, let's say, blood pressure climbs. Okay? That rise in blood pressure is sensed by baroreceptors that simply sense an increase in stretch. They send the impulses to the medulla oblongata, okay, that are going to bring about a drop in blood pressure. Okay? Sympathetic impulses to the heart slow down, whereas parasympathetic impulses increase. That results in a slowing of the heart rate. Okay? When you slow down the heart rate, you're going to get a decrease in cardiac output. If you inhibit sympathetic impulses to blood vessels vasodilate, which means a drop in systemic vascular resistance. So the decrease in SVR, the decrease in cardiac output, both contribute to a fall in blood pressure, bringing it back to normal. On the other hand, if your blood pressure drops, the baroreceptors will sense that drop in blood pressure, send signals to the cardiac and vasomotor centers that bring about an increase in heart rate, an increase in force of contraction. So your cardiac output increases, and you have an increase in impulses to the blood vessels, which bring about vasoconstriction. SVR increases. Both of these factors raise blood pressure. Okay?
That's fine.
Are we gonna go?
It's not very loud if it's
I hope that's not long. You're right.
You would think it would be like,
All right, let's just close the door.
There's a fire door, I don't think that's a good idea.
very nuts, very
I think that's a fire over
I really do.
All right, we said that in addition to the autonomic nervous system, the other component of short-term control is hormones, chemical controls. You know that norepinephrine and epinephrine are called catecholamines. They're produced and released by the adrenal medulla. Not the medulla oblongata, just the adrenal medulla. Okay? So, adrenal hormones are oftentimes released under situations of stress. Norepinephrine, one of its primary roles is to mediate vasoconstriction. Epinephrine is also going to contribute to vasoconstriction, but also increases cardiac output. Okay? Now, epinephrine is interesting because it causes generalized vasoconstriction in vessels to the heart and skeletal muscle. Those vessels vasodilate in response to epinephrine. But that's what you would think they would do in situations of fight or flight. You want more blood flow to the heart and the skeletal muscle, okay? So those vessels are going to vasodilate. So for instance, when you become severely hypotensive, that's a stress that triggers release of these hormones. Vasoconstriction, increased cardiac output, will help raise your blood pressure. This norepinephrine released from the adrenal medulla will bind to those same receptors that bind norepinephrine released from nerve terminals. So this norepinephrine, okay, will bind to beta-1 receptors on the heart. Okay, will bind to alpha-1 receptors on blood vessels. Epinephrine will also. Now, sometimes it's simply stress. If you're in a stressful situation or a fight or flight situation, you're going to activate the sympathetic nervous system through release of hormones from the adrenal medulla. Then your blood pressure is going to go up. Okay? Abnormally high, perhaps. Your heart rate's going to increase. But that's a reflection of the activity of these hormones. We're going to skip atrial natriuretic peptide. So I'm not going to ask you about